Oh, that was me, sorry.
With a special in low and middle income countries. So it's really a pleasure for me to join you today to have this discussion on long-acting injectable antivirals. That could be a groundbreaking development in the response to the HIV epidemic. As an activist, but also as ITPC, I believe that these medicines have the potential to transform the HIV treatment, but not only treatment, prevention as well. And it's been a while that we know that for many people, daily oral medication are not just a challenge. Sometimes they are just an impossible burden. And today, long-acting injectables could offer something profoundly different, the chance for people to receive effective treatments once every few months. This can make a real difference for those who struggle with adherence due to personal circumstances, to stigma, to unstable living conditions. But let's talk about the world where we live today, riddled with crises, wars, and conflicts. And if I have to speak from the region of the world I come from, which is, as many of you know, I'm Moroccan, and I come from the Middle East and North Africa, where due to wars, conflicts, accessing healthcare becomes in some places almost impossible. So long-acting injectables in this kind of circumstances could provide a lifeline. They could give people living in these circumstances the ability to stay on treatment even where their own lives are actually in chaos. So, but, and I will put a big but here, the potential of these medicines to revolutionize HIV prevention and care means nothing if they remain out of reach of the majority of people who need them. So right now, these medicines are very expensive. They are so expensive that they can be only rolled out in wealthy countries, while the rest of the world is going to be left behind. As it stands, this innovation will primarily likely benefit to the rich and leaving the rest of us to wonder, what good is progress if progress is not shared equitably? Then we have voluntary license agreements, often celebrated as the solutions, but they have glaring gaps. They typically include low-income countries, but they exclude so many middle-income countries, places like Brazil, Argentina, Russia, China, other countries in the Middle East, Latin America, Eastern Europe, and Asia. And these countries are homes of millions of people living with HIV or people at risk of HIV infection who will not see the benefits of these advances of science simply because of where they live. And I think this is not acceptable. So voluntary licenses are creating a system today where the rich can access the latest innovations. Some of the very poorest may be included through limited programs, but countless people living in middle-income countries are condemned to second-tier healthcare. They will be left with outdated treatments or prevention regimens, while the science that could change their lives passed them by. So for us, for ITPC, I guess for GMP Plus, and for the majority of people who are here in this webinar, this injustice cannot continue. As activists, we must challenge the system that perpetuates inequity. We must demand that these medicines are not priced out of reach. We need that voluntary licenses agreements are expanded to include all countries where people need access, and that Global Health Organization prioritize equity over protest. So to make it short and to conclude, I think today the reality is this: long-acting injectable could be a game changer. They could improve adherence, reduce stigma, and offer people living with HIV, but also people who are not living with HIV but at risk of HIV infection, a better quality of life. But their potential will only be realized if they are accessible to everyone and everywhere. So we've seen this story play out many times before. Breakthrough treatments come along, but their benefits are reserved for selected few. We cannot let history repeat itself. It is time to demand more. So let us use this space today to learn more with Tracy about these new treatment options or prevention options, and strategize to build momentum and push for a change. Because when it comes to access, I think every delay is a life lost, and every barrier is injustice that we cannot accept as activists. So yeah, thank you, GNP Plus, for the invitation, and I end here. Thank you.
Thank you, Ottoman. Thank you for doing that together with us. Tracy, floor is yours, guys. I put the link for the statement also in the chat. So after the webinar, please check it out and support us. And please come to the following webinars. We're gonna do advocacy together. It's not just, you know, just us educating each other. So Tracy, floor is yours. Any questions? Please put in the chat. Yeah, and we will try to manage it. Okay.
Hi, everybody. Happy Human Rights Day. And I want to thank the organizers and all of you for giving me your time. I have one small disclaimer for anyone who's been on one of my presentations. You know that sometimes deliveries come at awkward times. I'm expecting one, so I may need to run for a second to get the door, but I'll be right back to you. And just for those of you I haven't met, I've been an HIV/AIDS activist since 1990. I've done many, many things and worked in many different places, doing direct service, doing education, working on policy, etc. And it's really my delight to be able to do this presentation for you today. And I'm going to share my screen. I need screen sharing permission, please. It just says host disabled, participant screen sharing. Or if you want to share them, Sasha, I know you have them, whatever's easier.
Yeah, let me try. You should have a green button share, no? Okay.
Yeah, and when I press it, it says host disabled, participant screen sharing.
Wow.
So
How
I
fancy.
think maybe, okay, if I'm a co-host, that should probably do it. Yep, there we go.
Oh, nice. Okay.
All right. Can everybody see these slides?
We do.
Yes.
All right. So the reason why I'm doing this presentation is to provide actionable information that supports decisions among people living with HIV, their communities, networks, and allies about what to fight for, why to fight for it, and how to fight for it. So this isn't information for its own sake. And I'm going to be talking about the human right to health, the impact of patents on the human right to health. And then I wanted to go through a little bit of treatment and activist history and talk about the relationship between human rights and improvements in HIV treatment. And then I'm going to switch to why do we need long-acting antiretrovirals and talk a little bit about adherence. Really do a little animation that I made about drug resistance, talk about long HIV prevention failure, HIV treatment failure, what we have now in terms of long-acting HIV prevention and long-acting HIV treatment, and what's coming. So when we think of human rights, I think a lot of the times the first thing we think about are rights for key population, legal measures, anti-discrimination, ending stigma, etc. But there's also a human right to health, which defines health as a complete state of physical, mental, and social well-being, not just not being sick and the enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social condition. And this is the preamble to the WHO Constitution. And this is the spirit in which I developed this presentation. And I just want to say patents have a very chilling effect on the human right to health. They're one of several access barriers to ARVs and other medicines for other things, and diagnostic tests and vaccines. They give pharmaceutical companies the exclusive rights to produce and sell medicines. It allows these companies to set the prices and dictate who will have access to life-saving prevention and treatment. But there are legal safeguards that activists, communities, and governments can and have used to challenge patents and create access to affordable generic ARVs and other medicines. There will be another webinar that's more about access, but I don't think it's okay to talk about medicine without talking about access and that patents are such a barrier. But now I'm going to switch gears a little bit and talk about the relationship between better HIV treatment and human rights. And this really began for many people in 1983 when a group of 11 activists, all of whom were living with HIV and AIDS, developed a document called the Denver Principles to outline the rights of people with AIDS, and including to participate in medical and policy decision-making and to be recognized as people first. At the time, people were called AIDS victims, which they and all of us find inappropriate and offensive. So their statement was, we condemn attempts to label us as victims, a term which implies defeat, and we are only occasionally patients, a term which implies passivity, helplessness, and dependent upon the care of others. We are people with AIDS. And these principles are still totally relevant. They've led to changes in research, the way healthcare is delivered, and global movements such as a greater involvement with people living with HIV and AIDS, or GIPA, in 2003. So it wasn't until 1987 that AZT, the first ARV, was approved by the US FDA. And AZT was originally developed to treat cancer, but it was discontinued because it had too many horrible side effects. Scientists pulled it from a drug library and tested it against HIV and realized it worked. It was launched at $10,000 per person per year and given as 400 milligrams every 4 hours. And just think about what your life would be like if you had to take pills every 4 hours. You could never get a good night's sleep. It would interrupt everything. So that's really treatment-wise where we started from with antiretrovirals. The same year, ACT UP was founded in New York City, and it continued to empower people living with HIV and AIDS, and it really changed the US regulatory system so the people with urgent need could access medicine sooner. It advocated to have the definition of AIDS changed because before ACT UP did this, it excluded a lot of the conditions that women living with AIDS had, so they weren't eligible for benefits and services. And it created a place for people living with HIV and their allies to work with really powerful entities like the US FDA and NIH-funded AIDS Trials Network. So by 1994, AZT was used to prevent vertical transmission of HIV in high-income countries, dosed 5 times a day from the second trimester onwards, and given as an IV during labor. This was really painful and controversial because the reason this was done was to prevent the baby from getting HIV, but there was no provision to further care for the mother's health. So some people thought that this was really ethically wrong, but in the absence of having anything better to give mothers, really, other people who were pregnant thought it was great, but it really was the beginning. And as you can see, not really full human rights for women living with HIV, including pregnant women. So by 1997, a combination of patented ARVs, which was called highly active antiretroviral therapy, or HAART, entered the market in high-income countries at $10,000 per person per year. This gives you an idea of how overpriced AZT was 10 years earlier for the same thing. Not that this wasn't egregiously overpriced. It really kept these drugs out of reach for a while in low and middle income countries for far too long. But in that year, Brazil began to produce generic ARVs so it could give people free HIV treatment. And South Africa moved to address the public health crisis caused by HIV and AIDS by passing its Medicines Act to improve ARV affordability and access. But 39 pharma companies sued South Africa over the terms of this Medicine Act, saying that it would undermine research and development because they needed the money that they were overcharging the rest of the world for to pay for drug development. As this court case dragged on, 300,000 people died from AIDS-related illness in South Africa needlessly. But in 2001, pharma dropped the case, the first of several legal victories for AIDS activists in South Africa. There's my favorite slide. When people really fight, they can win. So by 1998, South Africa's Treatment Action Campaign, or the TAC, was founded to campaign for access to ARVs. It had many achievements, including massive community mobilization and education, winning a legal battle against the government to order it to provide ARVs to prevent vertical transmission of HIV, and helping to secure what has become the largest HIV treatment program. Because treatment was effective, it led to Cipla, an Indian generic drug producer, to introduce the first generic fixed-dose combination of drugs, two drugs at least, that are very rarely used today, nevirapine, stavudine, and lamivudine at $1 per day. So that was $365 per year, a far cry from 10,000. But then this created the opportunity for WHO to launch the 3x5 initiative in low and middle income countries, which was really the beginning of global ARV scale-up. Ultimately, 3x5 increased ARV access from less than 500,000 to 1.3 million people in focused countries. And it established HIV treatment as an essential public health intervention, despite being hampered by not getting enough funding. And although it was criticized as being top down, it got things started. In 2007, Brazil, which had threatened to issue compulsory licenses for patented ARVs and pricing negotiations, actually did it with efavirenz. And Thailand issued a compulsory license for lopinavir-ritonavir. Abbott retaliated by refusing to register any new medicines in Thailand, and there was additional backlash. At the same time, human rights continued. Nothing About Us Without Us, a manifesto written by people who use drugs, was released, and it demanded that people who use drugs have a meaningful say in decisions that affect their lives and health. In 2012, the FDA approved the first oral HIV pre-exposure prophylaxis called PrEP. And in 2015, the World Health Organization recommended ARVs for everyone with HIV as soon as possible, instead of waiting till people's CD4 cell count dropped to a certain point. And then in 2021, was the first approval of long-acting injectable HIV and prevention and treatment by the US FDA. So by the way, the reason why I'm using US FDA dates is they're super easy to find and they're often the first. It's sometimes very difficult to find dates in other countries, but it's certainly not because I think the US FDA is the only regulatory agency that matters. Okay, so where are we now? In 2023, there were nearly 40 million people living with HIV. 31 million of them were receiving treatment, but that means 9 million were being left behind. And there were 1.3 million new HIV infections, which means that since the beginning of the pandemic, nearly 89 million people have had HIV. And what's really concerning is, despite the scale up of treatment, despite everything, the number of new HIV infections has barely declined over the last few years. We need better access and better prevention. That's very, very clear. So I'm going to stop for a moment and take a break to see if anybody has a question.
Not yet. I don't see any.
Okay, great.
We can go into adherence, yeah.
So I'm going to shift to adherence. So the term for taking medicine as directed, like sticking to something, is called adherence. And HIV treatment is lifelong and it needs to be taken every day to work. In fact, the most important thing that a person living with HIV can do to stay healthy is taking ARVs every day. And the reason for that is it keeps enough of them in a person's bloodstream to fight HIV. It's the same way you eat a full meal to prevent hunger for several hours, but you don't eat 10 meals, so you don't have to eat for 10 days. You just want the right amount of something there. And adherence is really, really hard, but it's important. If people miss enough doses of their ARVs, HIV treatment can stop working. So people need to take at least 80 to 85% of their ARV doses, which works out to 24 to 26 of every 30 days. Now, some of you may have not seen that figure or have just heard you can't miss any, you have to take all of them. But we have better drugs now than we used to. So we found out the word for it is they're forgiving. They forgive you if you miss a dose now and then. Nobody's perfect. And it's certainly much easier to tell someone else what they have to do in terms of taking daily pills than it is to do it yourself. So I think this information is really important for people to have. And it comes from the US HIV guidelines, which are based on a ton of research. In fact, every little note you see in small print at the bottom is a paper I read or a source I checked or evidence I went into to make sure that all this information was accurate and that there is evidence to support what I'm saying. It's not my opinion, although if I have an opinion, I will give it to you also. I'll just let you know that that's what it is. So many people struggle to take pills every day, even for only 10 or 14 days, let alone for a lifetime. I've talked to a room full of doctors and asked them, put your hand up if you got prescribed an antibiotic. Put your hand up if you stopped taking them when you felt better. Put your hand up if you finished them. These are doctors. I would say about 30% of the doctors in the room finished their 10 days of antibiotics. That tells you a lot. And there are so many reasons why taking daily pills perfectly is challenging. And a lot of them are things people actually have no control over. But whatever the reason is, we know that missing enough doses of HIV treatment can cause serious problems. Okay, so I see a question. I'm going to stop and take it before I go on.
You see? Where you see it?
Whoops.
Yeah. Go ahead. I can see the hand, but I'm trying to see. I have to allow to talk. Yeah. Go ahead.
I think you're still muted because I can't hear.
Yeah. I gave a permission for person to speak, but okay. Tracy, I think we can proceed.
All right. Also, maybe people can put questions in the chat.
In the chat. Yeah, it's better in the chat or in Q&A section.
I'll stop at the end of this section too.
Okay.
So why does adherence matter? So each day, untreated HIV makes over 10 billion copies of itself. And some of these copies are not like the original virus. They have little changes called mutations. These changes happen randomly. And some of these changes or mutations are totally harmless. Some of them can even make HIV weaker. But other mutations can make ARVs stop working. Just like the way if you have an old key, but someone has changed the lock, it won't fit into a new lock. And that's called HIV drug resistance. So each time a person misses doses of their ARVs, it gives HIV a chance to start making copies of itself. And some of these copies might have mutations that make it resistant to one or more ARVs. So when a person begins taking ARVs again, the drugs won't be able to stop all the HIV in their bloodstream from copying that. And I think pictures speak a lot louder than words. So I made a little animation. This is not very scientific, but pretend the things that kind of look like olives are your CD4 cells. So HIV uses CD4 cells to copy itself. You see the little red things, but some of them, the copies have changes. Those are the mutated virus, the yellow ones. That's just a normal thing that happens as part of the process. So HIV drug resistance means HIV can continue to reproduce or survive even when someone's taking a drug that would normally kill it or limit its growth. And let's see what that looks like. These are the original virus. The ARVs can stop them, but then this mutated virus is left and it can keep making copies. Then when it multiplies, the drugs can't stop it. And it's important to know that a person can get a virus that's already drug resistant, or they can become resistant to ARVs due to stockouts, access barriers, missing a lot of doses, other life circumstances. I'm happy to stop if you'd like me to answer a question.
Yeah, I'm trying to allow to talk. Yeah.
You see Maria?
Yeah, that's what I'm trying to do. Ask to unmute. Maria, can you say something now? Maria? Now the hand is... Okay, we have a question in Q&A. What about injectables ARV for children? Any updates about pediatric ARVs?
Okay, things are generally approved in adults first. Once you're sure that there was the right dose, that they're safe and effective. Kids of different ages need different doses. So pediatric formulations usually come out after adult formulations. I'm not sure about the age for cabotegravir. I think it might be 18 or 17, but the current long-acting treatment and lenacapavir, the other prevention, is for people ages 18 and over. And I will be totally covering long-acting treatment in sections that are coming up too, but I wanted to take your question right away, and thanks for asking it.
There's also one more question, Tracy. Are there any scientific studies for the drug resistance or the copies of virus that are not treated by the available ARVs?
I don't know if there's a form of HIV that's resistant to all types of ARVs. There have been some types of HIV that are called multi-drug resistance, which means people have very few treatment options, but there are options, so just not very many. And what people generally need is a drug from a brand new class or a brand new family that they've never tried, and they need other drugs to use it with. So the reason why you use more than one drug to treat HIV is you want to stop the virus in different places. Otherwise, if you only stop it in one place, it can get around that. So I think of this as you're going out, you don't want anyone to rob your home. So you lock your front door, you lock your back door, and you lock the windows. If you don't lock all three, someone could get in the back door or the front door or the windows. So that's the principle behind HIV treatment. And usually the more drugs you have that are active against HIV, the better. And again, there are options for people that have a lot of drug resistance. Sometimes the media gets a hold of something and they get a little hysterical and they'll say resistant to everything. And I remember reading things like that and thinking, really? And then looking into it and finding out it was inaccurate or misinformation. So it's different from, say, tuberculosis, which is a slow growing bacteria where some people are resistant to all the known drugs. But again, and with TB, there are new classes of drugs in development for people living with drug resistant forms of TB. I hope that was a clear answer.
Very clear. Thanks, Tracy. There's also a question there in the chat, some confusion about the difference between lenacapavir for treatment as opposed to prevention, but I think we will cover that later, right? Or
Yes,
is it
I will be covering that when I get to that section. Thank you.
I also see a hand from Otman. Otman, go ahead.
Yeah, Tracy. In theory, the majority of people newly diagnosed with HIV respond positively to a kind of first-line regimens. Do we have people who, as diagnosed, they get first line and they are in treatment failure because they got infected with a kind of multi-resistant HIV? Has this been documented?
Okay, so there are some signs that people who have never been on treatment in some places and a small number have mutations that could make them resistant to dolutegravir, which is the backbone of WHO recommended first-line treatment. But dolutegravir is an integrase inhibitor, and it's a really good drug. And it has what you call a very high barrier to resistance, like putting up a very high wall around your house. And it's very hard to actually get enough changes in of HIV that dolutegravir will stop working. And I've seen a few presentations on this. Researchers are doing a lot of work on it, and they're still figuring out, what would really stop it from working, and do these changes that some people have that are called resistance mutations really matter? So I guess that's a long answer. The short answer is, I think if it happens, it's very, very rare. except in certain cases with long-acting treatment, which I will discuss when I get to that section.
Let's get to that section.
Any other questions?
No, go ahead.
All right. So resistance can develop to all sorts of other drugs, like antibiotics and antifungals, not just ARVs, and among lots of people, not just people living with HIV. So this isn't just a problem for one group of people. And, you know, poor adherence is often blamed for drug resistance, which I myself think is quite lazy because there's so many other things that are involved, like life events, war, natural disasters, barriers to treatment access, how far away the clinic is, how much it costs to get there, whether someone's job interferes with it, how long they have to wait, whether they're getting good quality care or they're treated with discrimination, they feel stigma, how well they're monitored, do they get good adherence support services, and whether ARV services supplies are interrupted. So again, this is not and should not be about blaming people. It should be about saying, we found a problem, let's find ways to fix it. So HIV drug resistance is most likely to happen with widely used ARVs, especially older ones. For example, efavirenz and nevirapine. Millions of people living with HIV in low and middle income countries have been treated with one of these drugs. They're from a family of drugs called non-nucleoside reverse transcriptase inhibitors, or NNRTIs. And they don't have a very high resistance barrier. So in some countries, at least 10% of newly diagnosed people already have NNRTI drug resistance, even though they've never taken ARVs. And the levels of NNRTI drug resistance are about 3 times higher among people who have taken efavirenz and nevirapine in the past. And as I said, some newer ARVs are more, but not 100% resistance proof, such as dolutegravir, which is one of the reasons why WHO recommends it. I see some questions. Should I stop?
Yeah, I think you can take that one.
Okay.
Should I read?
Is that you again, or is that an old hand?
That's an old hand. So we have here in the chat, are there any studies on Kabbalah resistance? It is an integrase inhibitor. Am I right to understand that if a person is resistant to dolutegravir, he will also be resistant to Kabbalah? Or if a person takes Kabbalah for PrEP, then gets HIV, will he be resistant to the dolutegravir?
You are very right.
Tricky.
Understand that. But again, I will get to that when I talk about the actual products. And I'm really excited to be getting all these questions. And I tried to think about what questions you might have and to answer all of them in this presentation. So you won't be forgotten. I'm also taking notes to make sure I don't forget them. But I want you to remember this thing about NNRTI resistance when we talk about long-acting. So HIV drug resistance can lead to treatment failure, which means the ARVs aren't working anymore. And people who have HIV treatment failure are at risk of serious illness and death. So it's really something to be avoided. So when a viral load is very low or undetectable, it means ARVs are working. And people who have an undetectable or low viral load don't transmit HIV to their sex partners. And even if it goes up to 1,000 copies, the risk of transmitting HIV to sex partners is very, very low. A viral load, however, that is over 1,000 copies means that ARVs are not working, called treatment failure. So people who have a viral load of 1,000 copies or above need support for adherence, and they may need to switch their ARVs. Just to look at this in another way, if it's undetectable, it's working. If it's between 50 and 1,000, it might not be working, but it actually might be working just fine. People need enhanced adherence support and a follow-up viral load test in 3 months. If it's over 1,000 copies, people who are taking an NNRTI as part of their treatment should switch. And people on other ARVs should get enhanced adherence support and follow-up viral load testing. Now, the reason why the recommendation is like that, in clinical trials, people who are taking treatment with dolutegravir and a couple other ARVs, some of them had a breakthrough viral load, but when they started treatment again, they completely resuppressed. So you don't always have to switch treatment, but if it's an NNRTI, you should. Now, here's where the things that people get blamed for really aren't their fault. This is where things can start falling apart. I don't think every person living with HIV has access to annual viral load monitoring. I'm not sure if anyone took the time to explain what viral load testing is, what the results mean, when they should expect to get them, which is soon, not months later, and what should happen. And people should know this, because if their viral load is over 1,000, they definitely need attention. If it's between 50 and 1,000, they need support and attention. And if it's undetectable, I think people need to know, hey, what you're doing is working. And if it's not working, they need to know, here's what we can do together to fix it. So I'm just going to ask, what do long-acting ARVs have to do with the human right to health? This is also in the WHO preamble to the Constitution. It could not be more relevant. Unequal development in different countries in the promotion of health and control of diseases, especially communicable diseases, is a common danger. The extension to all peoples of the benefits of medical, psychological, and related knowledge is essential to the fullest attainment of health. Okay, and at this point, I'm also happy to stop. And
yeah, we have questions. So let's start with the Q&A section. What are your views of countries still using efavirenz-based first-line meds? What do you think?
People living with HIV should have the right to select between efavirenz and dolutegravir. But my question would be, why are those countries still using efavirenz? Are there access barriers, IP barriers? Is it because the country is unaware of what WHO recommends and what advocacy strategies can and need to be used to make sure that people have access to the standard of care, whether it's talking about the WHO guidelines to people in government and saying, hey, you don't want to fall behind. Look at all the other countries around us. We want to hold our heads high. We don't want to be, ashamed that people aren't getting this important option. And if it's because of pricing, there needs to be a fight, because
Right.
everyone should have access to dolutegravir.
And we always have to fight. The other question, is resistance testing necessary before starting treatment?
Okay, in high-income countries, it's recommended, but low and middle-income countries don't do it. And if you're starting people on dolutegravir, which seems to work for almost everyone, nothing's 100%. You don't need to find out what they're resistant to, because you have something that's going to work for them. And my opinion about resistance testing is, if you're not going to do anything different because you did the test, you're wasting time and money. And here's why. The idea of first line, second line, third line treatment is that in countries that use a public health approach, you know what someone got. So if someone's never used a protease inhibitor, there's no reason to think they would be resistant to it. And you can switch them to treatment that includes a protease inhibitor. You don't need a resistance test to tell you that. Okay, for people who have been on ARVs for a really long time, who have stayed on treatment that's failing them, it would be a good idea, save for third-line treatment, because those drugs are expensive, and countries should really be able to pick the drugs that are most likely to work for that person, so they can respond well to their treatment. But you can also do okay without it. It's not the most necessary thing. I think a viral load, telling you whether treatment is working as a first step is a lot more important, and making sure that countries are able to provide, WHO recommended prevention and treatment options is really the first fight, not for resistance testing. There was a study a long, long time ago, and when I say a long time ago, like more than 20 years ago, and virologists who work in resistance, they get really obsessed with it, and they can talk to you for hours about it. But the question was, what works better? Doing two different tests, one looking at the genetic structure of a person's HIV, and one looking at how much of each drug is needed to stop their HIV from reproducing. Is that better than just looking at someone's HIV treatment history for deciding what they take next? And the answer was a treatment history is actually better. The problem is people don't always know it or have it. They can't remember the name of every drug they're on, because face it, all of us have a lot on our mind. But it just sort of reinforces what I'm saying, that you don't always need resistance testing. And if I was in a government, I would want people to have the best possible prevention, treatment, peer support, counseling, good care, etc., rather than saying people should have resistance testing.
Okay. Tracy, one question about the infants. So please, what is the normal CD count for infants? And what happens when an infant is born from a positive mother, is tested negative, but after some months the baby is tested positive? What is the pathology behind that? What is the reason behind that? Yeah.
Okay, so I am not an expert in infants. I apologize for that. What I can tell you is there are antivirals that dramatically lower the chance of the infant getting HIV before it's delivered, and antiretrovirals that will lower the infant getting HIV after it's delivered. As far as the normal CD4 cell count, I honestly don't know. I know for adults, it can range from 500 to 1,500. And I don't think there is one normal number. It's more of a range. Okay, so when you say testing negative and testing positive, the test you need to use is a viral load, not an antibody test.
Okay. Yeah.
And the reason why is babies are born with their mother's antibodies. So if the mother is living with HIV, the infant will test positive for HIV until that infant is about 18 months old, when he, she, or they gets their own antibodies. So back in the day, we thought this was a miracle. We were like, these babies that were born with HIV, they just got rid of it. But that wasn't what happened. They never had it. They just had the antibodies. What you want to look for is the viral load. Now, it could be that an infant who is born with HIV but got treatment to prevent HIV, it might have tested negative for virus and then tested positive because the treatment was interrupted or stopped. Or maybe there was an issue with the sample or the lab or the test. But I'm sorry, I can't give you a better answer than that. But what I can tell you is there are a lot of people who are born with HIV who are now in their 30s and 40s and have their own families. So antiretroviral treatment really works.
Yes, thanks a lot. We have several questions more, but I think let's go further. Yeah, and then come back to that questions. Okay.
All right. So researchers have made long-acting versions of ARVs as pills and injections. They last from a week to some that are come to 6 months. They can be used to prevent or treat HIV. And the idea is they're released very slowly at a steady level so a person doesn't have to take daily pills. This approach has already been used for antipsychotic drugs and contraception, so it's not a new approach. And as of December 2024, there are 3 approved antiretrovirals. Cabotegravir, which is known as Cab-LA, it is from the same family as dolutegravir, as our questioner mentioned, which is called integrase inhibitors. It's used by itself for HIV prevention or with ripivirine, long-acting, for HIV treatment. Long-acting ripivirine is from the same family as efavirenz and nevirapine. It's an NNRTI. It's used with Cab-LA to treat HIV. I'm just going to say this drug is the weak part of long-acting treatment. I think it might have been the one at the time that was the easiest to make into a long-acting version. But there are some problems with this drug, and one of the biggest problems is it is not recommended for anyone with a viral load over 100,000 copies. Now, as we know, when people get a positive HIV test result, they don't know what their viral load is. So why would you give them a drug that might not work for them right off the bat? You wouldn't. So this drug has some problems. I will talk about this more when I get to each section about the long-acting treatment. So lenacapavir, also to answer an earlier question, it's from a brand new ARV family called capsid inhibitors. It's used alone for HIV prevention, and it's approved right now with other ARVs as part of treatment for multi-drug resistant HIV. Okay, it will be approved next year for HIV prevention. It's just all the papers are in. I think the regulators are going over everything, but the only way it's approved right now is for multi-drug resistant HIV. It's also being studied to treat HIV, not just in people with multi-drug resistant HIV, but this is currently what it's approved for. And these are the 3 existing long-acting ARVs. So first I'm going to talk about long-acting HIV prevention, cabotegravir long-acting first, and then lenacapavir, or Cab-LA and Len. So these are the 2 trials that led to the approval of Cab-LA for HIV prevention and told us a lot about it. They compared once daily oral tenofovir FTC to injectable cabotegravir every 2 months. Okay, so these trials were blinded. People got either the real pills and a fake shot, or the real shot and fake pills. They didn't know what they were on. And 083 was in cisgender gay men and other men who have sex with men and transgender women. And 084 was in women. Now, they were designed a little differently, but it was really how well does Cab-LA work? And is it better than oral PrEP? Simple question. So these trials were stopped early because Cab-LA works so much better than oral PrEP, and everyone in the trials was offered Cab-LA. So overall, it was 79% more effective than oral PrEP. It was 88% more effective among women and 66% more effective among men and transgender women. Okay, why these differences? I will get into that. But just in terms of percentage figures, for people among all the women in HBTN 084 got HIV while on long-acting cabotegravir, 36 women got HIV while on oral PrEP, and with men, 12 men and transgender women got HIV while on Cab-LA, and 39 men and transgender women got HIV while on oral PrEP. So why was it so much more effective? In a word, adherence. People in these trials, especially the women, didn't take oral PrEP perfectly, just like in real life. When oral PrEP is taken as directed, it's 99% effective at preventing HIV from sex. And it's going to take some time as we fight for access to long-acting injectable prevention. In the meantime, it's super important for people to have information about and access to oral PrEP and adherence support. There's only 3 million people right now in the world on oral PrEP. That's all. Okay, we're not going to wake up with injectable PrEP in a week or two. So in the meantime, I would hate to have people getting the message like the oral drugs are terrible. They don't work very well. Instead of it's super hard to take pills every day or on a certain schedule. But if you do, this gives you a 99, it lowers your risk by 99%. Like, what's hard for you about taking pills? What could we do? How can we problem solve together to help? And how can we make sure that people have access to oral PrEP? But it's really all about adherence. Okay, I don't know why this isn't letting, there we go. So how is CAB-LA given? People have to get an HIV test to make sure they don't have HIV before they start CAB-LA. And it's given as a single shot into the buttocks muscle, right where you see that little X. The first shot will last for a month. After that, a CAB-LA shot is given every 2 months after HIV testing. And people have a window. They can get their shot 1 week before or 1 week after it's due. Now, the other reason why oral PrEP is important is if they miss that window and they're 2 weeks late, they're going to need oral HIV prevention or another method of HIV prevention, condoms, etc., because CAB-LA won't be working for them if they miss the window. And WHO recommends CAB-LA to prevent HIV from sex, but nothing works 100% of the time for 100% of people. So there's a really, really small risk of getting HIV while using CAB-LA. In clinical trials, it was just over 1%, or 41 of 3,446 people got HIV while they were getting CAB-LA. And this goes to the question about resistance. Of these 41 people, 10 of them developed resistance to CAB-LA and other ARVs in the integrase inhibitor family, which limits their HIV treatment options. Nobody's exactly sure why prevention failed for these people. But one thing to know about CAB-LA, it can stay in the body for months to years after the last injection because levels go down very slowly. These levels are too low to prevent HIV and they're too low to treat it. So it means that people who stop using CAB-LA or miss their scheduled injection need to use other kinds of HIV prevention. Okay, I just want to stop and see if there are any questions since I've gotten this far.
So there were questions before that. I think everyone is trying to process all of that information in our minds. But meanwhile, there was a question, for example, is it possible to switch to CAB-LA after second and third lines of ARVs? Or you will talk about the treatment later, or can you answer now?
I will talk about treatment fully later, so I'm going to defer that one. But it will be covered, I promise.
Yeah, there was also a question about the regulation at international level for safeguarding and clear monitoring of ARV treatment and performances from WHO. Yeah, but there are indeed, if you look at the chat, there's a question from Benjamin from Uganda. And could these regulations be integrated into national level regulatory? Well, they basically have to.
Well, there is WHO pre-qualification.
Yeah.
And there's recommendations. As far as country level monitoring, I'm really sorry, I'm not an expert on that, so I can't answer that one.
Mhm. Yeah, I think we can go further because no questions around that part. Mm.
Great, thank you. Okay, so also what are the side effects? Always good to know that. So the most common was swelling, redness, and pain where CAB-LA was injected, lasting for an average of 8 days. And 14 to 15% of people in the trials reported nodules, which are small, hard lumps under the skin. You can feel them, but you can't see them. They usually went away in a couple of weeks. Okay, and one thing I will say is I read a bunch of sub-studies, like looking at injection site pain from CAB-LA. Men reported more pain than women did, but both men and women, and sorry, they didn't collect data on transgender people separately, but both men and women said that over time it hurt less, which probably has a lot to do with fear of the unknown or knowing what to expect. So it doesn't hurt as much after you're used to getting them. And about 4% of people reported fever, chills, and flu-like symptoms after injections. And then up to 4% of people in clinical trials reported mild to moderate diarrhea, headache, fever and chills, tiredness, trouble sleeping, nausea, dizziness, gas, and stomach pain. So nothing comes without side effects. Those are the most common ones. There are other ones that are more rare, but I wanted to really focus on what's most common for the purpose of getting through a lot of information here. Okay, so CAB-LA was not recommended during pregnancy because there wasn't enough information on it. But researchers have been following people who became pregnant while using CAB-LA, and they've reported with data from over 300 people that CAB-LA is safe and effective during pregnancy. Now, the recommendation hasn't changed yet, but people who become pregnant while using CAB-LA will find this information very reassuring, and it's important that they get it.
Je ne sais pas si vous m'entendez.
So who cannot use CAB-LA? Sorry, should I stop for a minute?
Yes, I think Chantal who is our interpreter into French, is facing some troubles.
Je suis désolée, je parle français seulement un peu. Désolée.
I also don't know how to help, basically.
Okay,
No.
let me try. Chantal?
Oh dear.
Chantal, you're muted. Can you maybe tell us what's going on and how we can help?
Oh, yeah, sorry. No, I
Yeah.
said I don't know what happened, but I got off. And
Oh,
I'd like you to reassign me in the, to the French booth,
yeah,
if possible.
Helena, can you, yeah, somehow solve that?
So let me try again. Thank you.
Okay, sorry.
Okay, yeah, guys, if you can mute yourselves, yeah, and then we will proceed. Tracy, you can proceed further.
All right, so who cannot use CAB-LA? CAB-LA can't be used with rifampicin, which is used to treat TB, some forms, or drugs that prevent seizures. And sorry, I gave you the wrong information earlier. It's approved for people ages 12 and over. So it can't be used in people under age 12 or in people who weigh less than 35 kilos, which is about a little under 80 pounds, I think.
Yeah, and there was a question actually, are there any drug-to-drug interactions also studied for CAB-LA, for opioids, for example? Tracy, do you know?
Opioids, no, I always check for that. There aren't. And I went over all of them, and the rifampicin and the anti-seizure drug were really the ones that I thought might be problematic for people, but there is no interaction with opioids. All right, so about lenacapavir for HIV prevention, you've all heard a lot about it. There were two big trials, Purpose 1 in adolescent girls and young women in South Africa and Uganda, and Purpose 2 in men and gender diverse people ages 16 and over who have receptive anal sex with men. The trials were in different places. And here's what people got. The adolescent girls and young women in Purpose 1 either got Len injections with fake pills, or tenofovir FDC with fake injections, or TAF FDC with fake injections. In Purpose 2, people got Len injections with fake pills, or real pills with fake injections, so people didn't know, just as in the CAB-LA trials, if they were getting the real thing. And this is what has really stunned the world. How many people got HIV during the trial? 0 out of 2,134 adolescent girls and young women who got Len, versus 16 in the tenofovir FDC group and 39 in the TAF FDC group. It doesn't mean TAF is worse. There were just really twice as many people in the TAF FDC group. In Purpose 2, 2 people got HIV in the Len group out of 2,183, and 9 in the tenofovir FDC group out of 1,088. Now, both these trials were stopped early because Len was so much more effective, and everyone in the trials got offered Len if they wanted it. Now, the one thing is, this isn't a lot of follow-up. The women were followed and girls were followed for an average of 9 months. I think Purpose 2 was about the same. In real life, it won't be perfect, but it is by far the most effective form of prevention that we have, but mainly because it's of how it's given. And the main difference, it really is, again, adherence. And I'm about to tell you why. What you were really comparing in Purpose 1 and Purpose 2 was something that's given every 6 months versus something you have to take every day. Okay, so just like CAB-LA and oral PrEP, people need an HIV test before they start Len and before each injection. So you get 2 injections under the skin of the abdomen where those blue circles are in the drawing, at least 2 inches away from the belly button. People also need to take 2 Len tablets the same day as they get their first injection, and 2 Len tablets the day after their first injection. Then it's just 2 shots every 6 months. People can get Len injections 2 weeks before or 2 weeks after they're due. But just like CAB-LA, Len can last in the body for up to a year or even longer at levels that are too low to prevent HIV. So people who stop taking Len or are late for their scheduled injections need to use another form of HIV prevention. But there you have it. People have been totally astounded over these results. And I'll just stop to see if there are any questions about this.
There is a question, are there spots of injections painful, any reactions?
I will get to that in side effects. It's a great question.
Mm-hmm.
Anything else?
No, not really. We're still trying to solve the French translation. Sorry, it doesn't work yet, but we're doing our best, okay?
Okay,
Tentando o
so
nosso melhor. Então vamos para os efeitos colaterais da
Now
LEN,
it's
do
also
lenacapavir.
Spanish translation is also here.
oh dear, should I stop for a minute?
Yeah, please
Остановиться?
stop. Because now we hear all the translators.
Yes.
Helena,
just
can you
give-
try to?
Yes, yes,
Yeah.
give me
mhm.
a few minutes
Yeah,
to.
of course,
Thank you.
Take your time. Mm.
In the meantime, maybe if there are questions, people can put them in the chat. So
Ну,
I think
если какие-то вопросы по ходу возникают, можно пока в чат писать.
Exactly. That's your moment, guys. Meanwhile, I will put the statement again. Yeah, there are some questions also in the chat. Sorry, yeah, not in a Q&A section. So, are there any side effects with my OST methadone if I choose the injectables? If I understood correctly, Tracy, no, right? There would be nothing.
not with CAB-LA, but I will talk about lenacapavir because there's some caution.
Okay. Okay, then there was also a question. Okay, very basic one, but anyway, so that I'm translating from Russian. So the people who are taking injectables, then the tablets, they don't need the tablets, right?
Right, with lenacapavir, you take 2 tablets the day you get your first injection and 2 tablets the day after you get it. Then there are no more tablets. The only time you'd be taking tablets with CAB, LA, or LEN is if you miss injections and you need something, they call it bridging, until you get your next injection to protect you from getting HIV. That's if you wait too long and there's another reason why you can't get your next injection.
Yeah, very, very clear. We have translation now, right, people? All allocated to rooms, yeah? Are we? Are we good? We're good.
Yay.
Yeah. There was
Okay.
one also question, in case LEN oral pills are not available for the leading, could another PrEP pill be used instead?
I'm guessing probably, but I don't know how long you'd have to use it, because the idea of taking the pills is to just boost the amount of drug in your blood to make sure you have enough to protect you. I think it's a
Good.
really good question.
Okay, yeah, you can go further, I think.
Okay, so in Purpose 1, that was the trial in the adolescent girls and young women. Most common side effects were pain and nodules. And these nodules lasted for an average of 148 days. Okay, and it hasn't been documented, but there's a lot of gossip about research. And I heard that some of the women were like, hey, I don't like having these bumps. People can feel them. And I think this is going to be an issue, although apparently there are ways to it's a little drug that basically gets stuck in someone's body. There are ways to reduce the risk of this happening, and they're developing them as more people are using it. The other side effects are headaches, nausea, vomiting, urinary tract infections, and chlamydia. Okay, LEN doesn't give you chlamydia, but if you're having condomless intercourse, you're at risk of chlamydia. And so all this means is that the right people are in the trial, people who are at risk of HIV, who need PrEP. So it's actually, I think, kind of a good thing, because they were in a trial, they were getting tested for STIs, they got treated, etc. And that's sometimes what happens when you're sexually active. It shouldn't be a big thing. It people shouldn't be stigmatized. They should just receive treatment. So most of the side effects were mild to moderate. And I always look at, okay, how many people stopped? You know, how bad was it? I don't think it was that bad because only 5 out of 2,134 people who got Len stopped using it because of the side effects. Okay, in purpose 2, the study in men, transgender men and women, and gender diverse people, the most common side effects among people that got Len were injection site reactions and sexually transmitted infections. Again, this means the trial is enrolling the right people. It doesn't mean that lenacapavir gives you STIs. Also, diarrhea, headache, and nausea. And most of these side effects were mild or moderate. In the lenacapavir group, 7 out of 2,183 people stopped using it because of side effects. Again, not a large number, suggesting they're not that bad for most people. So who can't use Len? There's not enough information on its safety and effectiveness during pregnancy and breastfeeding. It can't be used with TB treatment with rifampicin, certain anti-seizure drugs, certain steroids, and some migraine or heart disease medicines. Len can make it easier to overdose on fentanyl and oxycodone, and it may increase the levels of methadone and buprenorphine. So a person might need a lower dose of methadone or buprenorphine, but it is really important that the person decides this, that no doctor or OAT program decides it for them. And I think people just have to see how they feel. And also, there is, I believe, a trial of CAB-LA in people who inject drugs, but it took forever. And there is right now a trial, it's small, it's 250 people, but to see how well Len works to prevent HIV from injection drug use. And this is so long overdue. People really deserve this information. They really need to know, will this protect me, or does it only, really protect me well from HIV from sex? So that information should be coming hopefully sometime next year. Any questions? Okay, I'm going to go on. Alina.
Yeah. Lina, allowed to talk. Go ahead.
Lovely. So Tracy, I just wanted to say that when we do the treatment literacy, uh, so we actually say that the data for OST programs is still awaited, right? Because
It-
it's not as if we don't have enough data, or we don't all these challenges that you have in an OST program. They just give you one particular dose and that's it. They don't give you too much leeway. So in treatment literacy, we would have to be much more organized in the harm reduction setting, I assume.
Yes, and if you're doing any of that kind of work, I would be more than happy to help you. First of all, people should get the right dose for themselves. So, it's not one size fits all, although I know in some places that's the reality. Second of all, everybody's body is different. So Len might be fine with methadone or buprenorphine for some people, but it might not be fine for other people. The only thing is, it's better if the people get that information than the programs, because this information has historically not been used well. I mean, I think back more than 20 years ago, I had to testify in a court case for this man who is on efavirenz, and it messed with his methadone and he relapsed. And I had to testify. It was because the program refused to increase methadone, even though they were sent information, and he actually won the suit, which made me very happy. But this has been problematic in many countries for years and really needs to be, I think, addressed as sensitively as possible, putting people who are using the drugs and the OAT at the center. And thanks, it's a great question. Anybody else?
Let's go to treatment. It's already 5 minutes before the end. Go.
I'm going. So I'm going to talk mostly about CAB-LA, Ripivirine LA, and CAB-LA and lenacapavir very briefly, and you'll see why when I talk about it. Who can use CAB or pivarine LA? Okay, the way drugs are studied in trials is how they're approved. And this is a big problem. This combination was studied in people living with HIV who were on ARVs who had a suppressed viral load, less than 50 copies. They also had to never have any history of treatment failure, no resistance to ARVs from the same families as cabotegravir or pivarine. And that includes people who took efavirenz or nevirapine even for a really short time. So the person who asked about switching, here's the problem. This is not a first-line regimen. And I think the real reason is ripivirine is not that strong a drug. Remember, I said it doesn't work for people with a viral load over 100,000 copies. When someone starts treatment, you have no idea what their viral load is. You don't want to set them up to fail with a drug that's not as good as other drugs. So it's not first line. Second line treatment is usually people switch if their treatment fails, but you can't use this if treatment failed for you. So it's really a switch regimen for people who are doing fine on their first line treatment. That is exactly how it was developed. And I see a question that I'm happy to take.
So
I-
yeah, we have yeah, there's a comment that the trial specifically on people who use drugs is a human right, right? Then so is it possible for a second line patients to switch back to first line after doing well? That's the question, for example. Yeah, and then also let me look into the other questions.
So are you really trying to get at is can someone on second line treatment who's fully suppressed use CAB or pivarine LA?
Yeah, I think that's yeah.
Okay, I'm going to talk about that a little bit in the next slides because it's a little complicated. And I want all of you to be able to see the information that I'm using to tell you what I'm going to say. But I really hate giving this information because people are so excited about long-acting treatment. And I'm like, it's not developed for most people. Even activists I know who work in high-income countries who often don't think of issues for low and middle-income countries were a little bit like, come on. You have to make things that people can use. So this is an example. What I always say is first to market is not best to market. This is not the best we can do. And I'm going to talk about what's coming.
One small question before you go. So can a person administrate the injection to themselves rather than only a doctor as a pharmaceutical company claims?
They really can't. And I'll talk about why that is. It would be awesome if they could, and we're going to get there, but not with this. And I'll explain why.
Okay, go ahead.
Okay, how well did it work in clinical trials? It worked as well as oral treatment. So this was people who were really adherent to their oral ARVs, who either stayed on them or switched to long-acting injections. And 1.4% of people who received long-acting treatment, which was 23 out of 1,651, over nearly 3 years had treatment failure. That's pretty low. So the treatment failure rates are low, but the price is high. People who have CAB, ripivirine, long-acting treatment failure, they wind up with resistance to at least ripivirine and sometimes CAB too, and that means other integrase inhibitors and other NNRTIs. So you might be asking, well, first I'm going to say how it's given, then I'll talk about why it fails. So it's given as 2 injections in the buttock muscle, but you need to use a longer needle for people who have a body mass index over 30 to make sure that the ARVs reach the muscle instead of getting stuck under their skin. The second injections are given a month after the first injections, and it's 2 injections, 1 for each drug. Okay, and the first injections are at a lower dose, the second injections are at a higher dose. So the second injection's 1 month after the first, and then every 2 months. So these ARVs stay in the body for months to years at levels that are too low to fight HIV. A person who misses a scheduled injection or stops their injection needs to continue HIV treatment with something else. That's really important. So researchers are looking at cabopivirine long-acting in other groups of people living with HIV who weren't in these trials, including people who have struggled with adherence to daily pills. They've had really mixed results, but most of these trials gave injections once a month instead of once every 2 months. And this is important for 2 reasons. 1, it's less convenient for people and for healthcare systems, and 2, it's twice as expensive. And the treatment failure rates in some of these small studies have been a bunch higher than those from clinical trials. But some of the people in these small trials had a detectable viral load when they started the long-acting ARVs. So they weren't really the group of people that are supposed to be using it. But as we get more evidence in the future, cabopivirine long-acting might be used to treat people who it's not currently recommended for. But that's not happening in too many places right now. So there was one trial in people who are really struggling with adherence called Latitude, 434 people who either just stopped showing up for clinic visits or had a viral load over 200 copies while they were taking ARVs. So they were given money to take oral ARVs and have an undetectable viral load for up to 6 months. And then they were assigned randomly to either stay on their oral ARVs or switch to long-acting treatment every 4 weeks. And at week 52, treatment failure was 2 things. It was defined as either stopping your oral or long-acting treatment or having a viral load over 200 copies while you were on your treatment. So overall, long-acting treatment failed for 6 people, plus 3 more who stopped because of side effects, versus 29 people on oral ARVs, including 1 who stopped ARVs because of side effects. Okay, 25 people overall stopped long-acting ARVs and 30 people stopped oral ARVs. So really what it means is the treatment failure rate with long-acting treatment was 24%. It was almost 39% with oral ARVs. So people had a lot of different conclusions from this. One was long-acting ARVs are better for people who struggle with adherence. But what I thought about is having 1 in 4 people have treatment failure with long-acting drugs means you're still not doing something right for people. And all those other things that aren't medicines, like support services, peer counseling, all of that also really matters. Okay, so this, I don't think it was exactly a home run for long-acting treatment, but I think it will be very helpful to some people. And then a lot of people have said, you know, low and middle income countries don't do resistance testing. There's high rates of resistance to efavirenz and nevirapine, which means ripivirine might not work. What do you do? So there was a trial of CAB-LA ripivirine in Africa, in Kenya, South Africa, and Uganda, and regular treatment programs in real life settings. They didn't use drug resistance testing. They did viral load testing every 6 months. And although people in the trial all had a viral load under 50 copies for 4 months to a year and no history of treatment failure, they really looked like the epidemic. Almost all of them were Black, more than half were female, 21% had a BMI over 30, and almost 75% had been exposed to NNRTIs. So what happened? At week 48, they were pretty much the same. They worked just as well. There were 2 cases of treatment failure among people who got CAB-LA and ripivirine. They both had on-time injections, but it didn't work. Why? Why does it fail sometimes? So there are some known risk factors. Having one or more of the following, a subtype A6A1, which is more common in Eastern Europe. But this sort of testing is only done in research laboratories. Nobody knows what their HIV subtype is, unless they've been in some weird clinical trial that looked at it. People who had resistance to ripivirine. And resistance testing is rarely done outside of research in many low-income countries, as I said, because it's expensive and there's a long wait for results. People with a BMI that's over 30 kilograms, especially if the right size needle is not used, because the drug may get stuck in the skin and not go into the muscle where it's supposed to go. Being late for missing injections, and not having high enough drug levels for other reasons that really, honestly, we don't understand right now. So sometimes this just doesn't work for everybody. And sometimes there isn't an obvious reason why. And the most common side effects were injection site reactions. The nodules lasted for an average of about 3 days. And the other common side effects reported by about 8% of people were fever, tiredness, and headache. So who can't use it? People who are pregnant and breastfeeding. There's not enough data to recommend specifically ripivirine because now we have more data on CAB-LA. Can't be used with rifampicin or anti-seizure medicine. People who live in places where constant refrigeration is not possible because ripivirine must be kept cold during delivery and storage. And people who are living with hepatitis B can use it, but they will still have to take pills every single day for the hepatitis B. So not sure whether taking a few less pills a day is really going to make a difference to people who still have to take daily pills, because the point of this was not to. Now, all of us have been like, what about CAB and LEN? LEN might be great. You know, it doesn't have some of the problems that ripivirine has, but both ViiV and Gilead didn't want to support those trials. I think they said you could do one in 25 people. Well, you can't make decisions about treatment for millions of people based on 25 people. But these companies want to make their own combinations without having to share profits. The only available information comes from 8 people at 2 French hospitals. Okay, so you certainly can't make conclusions out of this. And most had been on oral treatment for 25 years. They had resistance to ripivirine, and 4 of them had CD4 counts below 200. So they couldn't take CAB-LA, ripivirine-LA. They were given CAB-LA with lenacapavir, and all have remained suppressed for a couple of years. That is all we know about that combination. And just to think, healthcare systems are going to need to deliver ARVs. They're going to need to provide counseling to people, including the risks and benefits and side effects, offer HIV testing at each visit, train healthcare workers to give these injections, including in the abdomen or buttocks, in the muscle or under the skin, and using the right needle. And so they don't hurt as much and they're less likely to give people nodules. They need private space for the injections. They'll have to adjust scheduling and appointment reminders for different long-acting ARVs at 1, 2, and 6 months, and make room to store them, especially ripivirine, which needs to stay cold. And before I go to what's in development, I see there's 20 minutes left. Let me stop and take a few questions. Do
We
I
have
have any?
now troubles with Russian. I'm
Oh,
trying to
dear.
solve that. So for the questions, there was a question like, is there any opportunity to take with people who have less than 50 copies, can they take LEN? There was one question. Also, there was a question about pharmacokinetics of Cabelet and lenacapavir. So there are these two questions.
There's no published PK data, pharmacokinetic, how drugs move through your body on CAB-LA and LEN together. All there is that information from 8 people at 2 hospitals in France. Okay, so I can't answer that. As far as LEN, it's only approved right now to treat people with multi-drug resistant HIV. It's not approved, although it's being studied in people who have less than 50 copies as part of treatment. Those studies are happening right now. We don't have the results yet. So say in the United States where LEN is approved for part of treatment for multi-drug resistant HIV, it's priced at $43,000 per person per year. Nobody is going to be really giving it out to people who don't really need it at that price. So, but I think as more people use it for more things and all of us continue the pressure on Gilead, the price should come down, but that will come up in a future webinar. And I really want to get to tell you about the pipeline before the end of the webinar.
Tracy, and we were supposed to have webinar for an hour and a half. So can you like
Oh my God,
really
where I
speed
thought
up?
it was
Yeah.
2. I'm so sorry.
No. And I think also the translators should be already very tired as well. So let's do the pipeline and yeah.
Okay, what's in development, there are a lot of oral pills. There are 2 late-stage trials of 2 pills that you can take once a week. All these trials are in virally suppressed people right now, which is not necessarily a good thing, but we'll talk about that at another time. There's a drug called ulonivirine or ULO, that's an NRTI. That's an oral once weekly being paired with another once weekly drug. An oral once weekly integrase inhibitor and a form of lenacapavir, oral once weekly. So there are all these oral once a week things coming. And then there are other oral drugs in the same family as LEN that are currently in mid-stage development. And this might be the kind of long-acting thing people can give themselves instead of going to a clinic. There's an ultra long-acting injectable version of CAB that could be given every 4 months in mid-stage development. Something that's going to enter trials in people next year that would be every 6 months. And there's one in very early trials given every 6 months. All of those are from ViiV. Gilead and Merck are working together on a long-acting injectable with a new class called NRTTI with LEN, currently in the first stage of human trials. And then there's a long-acting integrase inhibitor currently in the first stage of trials, ultra long-acting. So really the point of this is there's not a lot of information on any of these, but that there are other better things coming, that the, you know, this first long-acting treatment has some limitations, but what's coming next is likely to be better. And there's a need to get ready. Communities need information to build demand and develop strategies for implementation and access. Healthcare systems and the people who work in them will need to prepare. Pharma needs to be pressured on access and pricing. And governments need to fight for affordable long-acting ARVs. And we as communities need to push them to do so. And I'm going to close with some really beautiful words said 20 years ago at the Bangkok International AIDS Conference. Governments and corporations hate activists because we know what they are up to, and we are pulling the masks of fake concern from their face to reveal their true nature. But to me, activists are to be honored. Activists are my true friends. They stand by my side when I face discrimination and injustice. They have the courage to stand up to those in power who use their positions for their own benefit. They are the ones who can help provide a way forward to fight AIDS and injustice in this world. Today, I urge all of us to dream of a day when our world will be filled with love, sharing, and peace. And I believe that when we dream together, our dreams come true. Paisan Suwanawang from Thai Treatment Action Group and Thai Drug Users Network. And that is my last slide. Thank you so much, everybody. If anybody wants to stay without interpretation, I am more than happy to stay and answer questions.
Thank you so much, Tracy. Very powerful last slide indeed. And I remind you people that there were quite a lot of questions about the slides. The slides will be available. Also, Tracy have done the material. So everything you couldn't catch, in this presentation, unfortunately, by now they are only in English, but we're gonna translate them. So you will have the materials as well. Indeed, Injectables is quite a new world for all of us, so we have to really educate ourselves to start to understand how it works. And in January we're gonna have one more webinar which will be focusing on the access, on the prices, so we'll speak further and more about that. And then we also will have a third webinar when we will speak about what can be our advocacy strategies and what can be our solidarity and how we can work together, to make this world a bit better place, for all of us.
Absolutely. And I'm going to stick my email address into the chat.
Yes, please.
If anybody has questions, you can drop me an email. And I really thank you. I'm sorry it went over. I was trying not to talk too fast. I really want to thank the interpreters for their patience with me, especially, as well as
And
the
with our
technical problem.
technical stuff.
And just really happy Human Rights Day, everybody. In a way, this is like so meaningful to me because this is what it's all about. This is what made me want to read a bunch of boring scientific papers and become an activist.
Yes, absolutely. And once again, people, we have a statement on our website, and I also believe on ITPC one as well, with a statement about the treatment access, and we have an open letter. Please read it, make yourself familiar with that, and please sign and support us. We are demanding the governments and international bodies, to do something with an access. Thank you.
Please sign the letter, which I also need to do. I think, pharmaceutical companies should not have more power than a government. Like, screw that.
That's why we are even not aiming with this letter pharmaceutical companies. Let's stop talking to them. Let's talk to governments.
Exactly.
Okay.
Should I take a question? Because I see one.
Yeah, if you see any. Yeah,
Yeah.
I see.
Rajesh?
Rajesh, yeah, allowed to talk. Yeah, Rajesh, go ahead.
Namaste, everyone. It's me, Rajesh from Nepal. Am I audible?
Yes.
Yes.
Okay, then the situation in Nepal, and especially in Asia Pacific, it's very different. You see, now we are talking about a cab, LA, but people here in Nepal still, they are unaware about the side effects of TLD. So I have shared a link there, the study, which has indicate that who are using dolutegravir around 3 years, they are facing a sugar problem. I mean, they have lots of other issues. So this could be a very important issue for GNP Plus to rise up, to have a research on the matter of this, because you see, we all are having dolutegravir since from 5, 6, 7, 9, 10 years. And in Nepal, since from 4 years, we are having dolutegravir. So recently, I am diagnosed with a sugar.
Well, Rajesh, this is a whole, huge. Let's talk about that more. Yeah, but indeed, we have to start discussing things like that, and
Yeah.
a whole discussion. Unfortunately, unfortunately, we just don't have enough time for that by now. Yeah, but indeed, let's speak about that later.
Okay, I'm here. I'm here, Sasaf, to support.
I know how to find you. Yeah.
Yeah. Okay. So thank you so much, and namaste. It was a great webinar. I have learned a lot. Thank you, everyone, and namaste.
My
Yeah,
pleasure.
thanks,
Namaste.
Rajesh.
Happy
Thanks for coming.
Human Rights Day.
Yeah. Yeah, there are two more. We can leave the Helena. We can let the translators go if they, because we were not making a decision. There are two more hands, Lina and Vim. So Lina, yeah, go ahead.
Yeah, so I just wanted to say thank you. It was nice and slow and very useful and worth repeating in different regions, I wanted to say, and maybe combining it with a critique of the voluntary license specific to those reasons. I just wanted to also say that, this issue, and this is not relating to the long acting, but this issue of NCDs, whether it's diabetes or hypertension coming along with HIV, is coming up again and again in our communities. And we worked with GNP and, I worked with Helen Bygrave and Krista, and the South Africans are doing quite a bit of work on this. And it's something that we should put on the agenda because increasingly people living with HIV will need the treatments for hypertension and diabetes. And of course, there are a bunch of people who've already worked on this. So I just thought worth offering that resource if anyone wants to be put in touch for a webinar on that. Yeah.
Absolutely. It's so important. I'm living with type 1 diabetes, so I have to give myself 4 to like 6 or 7 injections a day. And it's not the best standard of care, but everyone in the world who needs it deserves access to it.
Indeed. Vim, go ahead.
Sasha,
Bim,
to continue the recording or?
No, we stopped the recording.